So I have the privilege of introducing Dr. Staci Arnold, who's an associate professor of paediatrics at Emory University School of Medicine. She's a non-malignant hematologist with a particular interest in haemoglobinopathies and bone marrow failure syndromes, and has sort of a particular interest over and above that in caring for those who undergo stem cell transplantation. As a clinical academic, Dr. Arnold's research focuses on demonstrating improved quality of life, survival, and cost effectiveness of new therapies, but also probably equally important, addressing sort of access to those therapies, including those curative therapies. It's quite poignant in the UK given recent news about Casgevy. We have had the pleasure and the honor of hosting Staci at Imperial as our first first person in the visiting program that we have established here fairly recently. And for the last 2 weeks, he's been interactive, questioning of our service, and also giving us an insight to what she's doing over in the States. So, given that she's been so beneficial to us, she has kindly agreed to present some of her work to us today. So over to you, Staci. Thank you.
Thank you, Stephen, and thank you everyone on the call, and for those of you that have accommodated me with meetings in person or otherwise. So I look forward to sharing what I hope is a good snapshot of some of my work on the research side, and in particularly hoping to color both the cost effectiveness and discuss access around curative therapies for sickle cell. So over the next several minutes, what I hope I can do is just give a little bit of background into the area, more from a US perspective, including some discussion of both retrospective and prospective studies that we have done. And then what I see the next steps are in terms of future directions, and hopefully having an opportunity not just for questions, but for discussion. So why do we even talk about cost effectiveness of care in general? And I use this slide in particular, which at least they don't have as beautiful of a graphic with the current numbers, but just to depict visually where we are in the healthcare industry in terms of costs. So lower healthcare costs are in red, and the more blue or purple you get, the higher your annual healthcare expenditures are, as depicted here. And as you see in the US, we are winning, unfortunately, with being in the purple and therefore having the highest annual healthcare expenditures. But if you also look, there are other countries that are sort of in the yellow or the teal, including the UK, which is right in the middle of the road in terms of healthcare costs and expenditures. What we also see when we break these costs down is, unfortunately, every single year, these numbers seem to be increasing or sort of staying stable at the higher levels they have been in previous years. And so for the US, we're talking $3 to $4 trillion a year, which can be about $14,000 per person. But then we also look at these healthcare expenditures in terms of how much of our gross domestic product does it reflect? How much are we actually bringing in terms of income and revenue is actually taken up in terms of healthcare? And for the US, that's almost 20% of our gross domestic product. Now, when I looked for numbers for the UK, again, of course, your numbers are far less, but still quite high. The most recent numbers suggest about 300 billion pounds and around 11% of your gross domestic product. Now, as I alluded to, though, the bulk of this talk is going to be from a US perspective, and I highlighted there In particular, me, where I work currently and live is in Atlanta, Georgia, the Gold Star. But why is Atlanta important in terms of sickle cell? And this graphic depicts the prevalence of sickle cell in the state of Georgia, with lighter colors being less sickle cell and darker colors, in particular dark blue, being higher sickle cell. And you see that Atlanta and the surrounding areas have the most numbers of sickle cell in the state. And in particular, our center actually cares for the most sickle cell patients in the country, with about 3,000 patients cared for at our center. And that's pediatric patients specifically. So this is very important to us in our population. And so I won't share with this group because I think you know exactly what sickle cell is, but in the US, that impacts about 100,000 people, but of course, several million worldwide. And in the UK, I understand the numbers are anywhere from 15 to 20,000. But what we know, no matter where these patients are, is this is a lifelong illness with very unpredictable episodes and significant impact on not only mortality, but quality of life. In the US, we've been able to make great steps in terms of improving survival and hopefully improving quality of life with regimens and impacts of care over time. Even going back as far as the 70s, when we implemented our National Sickle Cell Act that allowed for us to include hemoglobinopathy screening on our newborn screens. And what that then allowed us to do was do early intervention with preventative penicillin as well as immunizations. We also benefited in the late 90s of a study of use of hydroxyurea in adults with sickle cell disease, and found that that greatly reduced mortality, reduced complications, and even decreased hospitalizations. But unfortunately, recent studies show that only about a third of the population is actually even using hydroxyurea. And this includes estimates with our baby hug study that occurred sort of after this graphic. So in around 2014, they published the results of that data showing that if you started hydroxyurea in children as young as around age 1, you saw similar benefits from the medication, but of course that comes with some costs. However, the cost of care for those receiving hydroxyurea, although around $14,000, somewhat balanced out in terms of the reduction in hospitalizations. The other therapy that we have used and benefited from for years is transfusion therapy, in particular in our population who has had or is at risk for stroke. But again, that comes with significant costs, where we estimated about $40,000 per year. So fortunately, again, with these interventions, we've actually improved our survival. Recent study has actually showed with using baby hug and other interventions, we're up to age 58 as the average expectancy. I think it's in the high 60s in the UK. But if anything, if the UK is anything like the US, that's still far less than the average life expectancy of other individuals living in these countries. And so that says we still have far to go. And in particular, that's just sort of the traditional outcomes of survival that we look at. But what does this mean in terms of the daily lives of the individuals living with sickle cell, in terms of their healthcare experience and in terms of the cost of their care? And so we know individuals are having high rates of emergency department or A&E visits, as well as hospitalizations. In the US, we track one of our public insurance services, Medicaid, and what we call a super utilizer. And that's someone who's had just 4 or more hospitalizations per year. And consistently, sickle cell ranks in the top, and most recently was 5th among the top diagnoses of frequent hospital stays. Studies have translated that degree of care into actual costs, with a lifetime cost of $1 million per patient living with sickle cell disease, and a total health system burden of 2.9 or almost $3 billion per year in the US. So it takes a substantial amount of money to care for these individuals. And for that reason, given the quality of life impact, given the survival impact, given the cost impact, I think it's also important to consider cellular therapies or even what are called curative therapies in this landscape. And so for years, hematopoietic cell transplant was the only cellular therapy option that we had, and in particular in the matched sibling donor setting. But unfortunately, many individuals do not have a matched sibling donor. And so that impacts the utilization of cellular therapies throughout the world and even in the US. And this shows, though, that even with that challenge, we're seeing the numbers of transplants across the world increasing over time. And this is just depicting a 10-year period. And given some of the challenges in finding a sibling donor, the US has looked at, well, how do we expand our access and our availability to transplantation by looking at alternate donor sources. And again, we've had really great outcomes in survival of matched sibling donor transplant, with in some measures looking almost as high as 100%. But the further away you get from a matched sibling donor, the lower your survival. But even with that, we're still having pretty good outcomes of transplantation, with an unrelated donor being at as high as 87% for sickle cell. But again, at the same time, we have to balance those traditional outcomes with the day-to-day impact on patients. And in particular, with transplantation, there's a socioeconomic impact. In fact, because it requires weeks of inpatient hospitalization and physical isolation of both the patient and their caregiver. In the US, you have to have insurance to be able to get a transplant. And transplant is often tied to your employment. So if you're isolated and in the hospital, then you're having missed work and wages. And how are you balancing that? And then potentially we're putting patients and families at both short-term and long-term financial risk that we haven't really adequately reported, or at least when I entered into this field. And so that's in part what I set out to do, was just try and, can we characterize the landscape for this treatment? So before I get into talking specifically about cost and cost analysis, I always like to give this convention, because I don't assume that people are health economists and know how to do this work. And so first, I think we must be clear in a healthcare setting, the difference between costs and charges. And all the data I will report are either direct measures of cost or having charges adjusted to cost. Because in the example of this water bottle, usually what we're paying for a bottle of water, the price we're paying is actually what we're being charged. It's not what it costs to actually get the plastic, fill it with water, beautiful spring filtered water, because the cost is what's incurred for that. And the price or the charge is what's marked up that you then see as the consumer. Okay, so that's why we want to know in terms of healthcare what it actually costs and not what you're being charged. Also in healthcare, there's another factor that sometimes comes up, which is called reimbursement. So in the US, reimbursement is what the insurance pays you after you've charged them for care, which often that reimbursement is far less than what has been charged. And in some instances, even less than what it costs. But then, as I alluded to, even just in the discussion of this talk, perspective is important. And so when we're talking about costs, are we talking about costs to the patient? Are we talking about costs to the healthcare system, or even society? And it's important to know those perspectives when you're looking at these type of analyses. And then even with these analyses, there are varying types. So a cost analysis is simply reporting it costs this much to have this bottle of water, or it costs this much to transfuse someone. And some of the data I presented previously was a simple cost analysis. But what cost effectiveness and cost benefit does is factor in other metrics like quality of life, like societal impact, and other variables to give you a more robust or rounded out assessment of these treatments. So first, let me just walk you through some cost analyses that were done, again, just to set the stage. So in the US, a group from CIBMTR, the Center for International Blood and Marrow Transplant Research Registry, looked at just the first 100 days after transplantation. What does that cost? And for an autologous or a self-donated transplant, it's around 100,000 US dollars. For an allogeneic or another donor other than the patient, it's around 200,000 US dollars. So that's a good bit of money. And what they also saw is that most of those costs are incurred with that initial transplant hospitalization, and that children, their transplants cost more than those of adults. This group also looked at, well, from a patient perspective, what are they paying and what are their costs? And in particular, looking at out-of-pocket costs. And it was a small sample that actually they were surveyed and completed, in essence, a cost diary, and determined that the median out-of-pocket expenses were around 2,500 US dollars. And the vast majority of those funds were spent on lodging. And in particular, for those who required lodging, those costs were even higher compared to those who did not, which is important because often transplant centers are not necessarily in the neighborhood or region of those who need the transplant. People have to travel to centers to get that cellular and potentially curative therapy. So that's the big picture stage. But when I started this work, we didn't even know what a transplant for sickle cell costs. And so this was my first publication out of a fellowship or training in the US at the center in New York where I worked. And so what we did, we looked at not only the cost of care, but we also did look at quality of life. And I won't present that work here. I'll focus in on the cost of care. And in particular, we wanted to look at healthcare utilization because we know individuals with sickle cell disease are interacting with the hospital and healthcare system quite a bit. And then also looking at the actual numbers. And so we looked at it across two different groups. Those individuals who received a transplant, what was the change in their utilization from before transplant to after? And then also comparing those individuals who were transplanted to those who have sickle cell and were not. So you see in the red, those who had sickle cell and were not transplanted. And then the blue is pre-transplant utilization and purple is post. And what you see is across the board, across all groups, there was a reduction in utilization in terms of length of stay, in terms of visit, whether inpatient or outpatient. So that's exactly what we want to see with transplantation. We also did look at costs, and at least in this single center study, we did not see a significant reduction in inpatient costs, but we did see some reduction in the cost of those who were transplanted. But this suggested that maybe if we continue to follow, or if we looked at a larger cohort, not just our single center, which we did have some skewing of the data, that maybe we might actually see some trends. So that then leads to the next study and publication where we partnered with the CIBMTR, taking their robust data on transplant outcomes, and clinical information, and merging that with a cost and healthcare utilization database. And so what we found that on average in the US, it costs about $400,000 to transplant someone with sickle cell. And that's the bulk of the cost is just in that transplant year, okay? And we also looked at the cost before and after transplant in the years leading up to and years after, and saw that that's really sort of a drop in the bucket compared to the cost of transplant itself. We also wanted to know, were there certain factors that actually influence these costs? And we looked at patient level variables as well as treatment level variables to do so. And what we found is that those individuals who had a stroke before transplant, who had frequent veno-occlusive episodes, as well as those who had, oops, sorry, did I jump? Those who had unrelated donors, cord blood donors, had higher costs of care compared to those who either did not have those complications going into transplant or who either had a matched sibling donor or a bone marrow donor source. We also looked at timing of transplant because we know over time some of our supportive care practices, some of how we did transplant change, and somewhat as expected, after those changes where we were getting better outcomes and in essence doing better transplants, the costs were also reduced. So in summary, in general, caring for someone with sickle cell can have a high cost. And transplantation is substantially higher in cost even with that. We also, at least from our data, saw that sickle cell complications and donor type were the strongest predictors of costs in terms of transplantation. But at the same time, transplant was reducing outpatient costs, length of stay, and admissions after that treatment. And so could that translate into other cost benefits later? And so that then got into some of our prospective work where we wanted to actually follow individuals from transplant through the next several years to not only look at cost, quality of life, and survival, but also look at some of the long-term or potentially late effects of transplantation, in particular in a population of children who ideally would have a longer period of survival after transplant. And at first, what we wanted to look at, in addition to traditional outcomes, were also some of these patient-reported outcomes, which in some ways is self-explanatory, but really focusing in, since cost of care is so important, financial hardship, which is more of the impact of the healthcare on spending and spending of income and expenses. So, for example, people often negotiate their household expenses for their medicines in the US. I guess the convention's a little different potentially in your healthcare system. And so we wanted to try and characterize and or quantify that. And then also look at quality of life. So I'll start with some of our financial hardship data. And in particular, just talking about, well, what is the financial hardship of transplantation in general? So some studies have been done looking at almost 500 patients who were transplanted at multiple different centers and saw that over half of them had some level of financial hardship after transplant. And almost half of them had decline in their income. And there was some degree of correlation between financial hardship and worsening in their overall patient-reported outcomes, including quality of life. A similar study, even looking at autologous and allogeneic transplant, saw similar findings, but they did see that at least 3 years after transplant, the vast majority of patients were actually working full or part-time. But the thing that seemed to influence that the most was those who developed chronic graft versus host disease. So they again suggested areas where we might need to investigate further. The challenge is that we don't have a good instrument to actually assess these things. So these were both done in studies that were for malignant diseases and in adult populations. And so what we tried to do is adapt those measures to our sickle cell population. But in order to do so, we had to determine, could the instrument even assess the measures we were trying to quantify? So in particular, did people know what quality of life was, and could they characterize that? And this slide just, or graphic, just depicts in their own words what that meant. Similarly, financial hardship, we were able to assess that as well, and several other metrics assessed in the survey or the proposed survey to try and see if we could use this tool to assess this. And ultimately, what we were able to find is that individuals could consistently define key terms. So we were doing well in that aspect. They could also convey the financial impact of transplantation in the scope of the survey. But there was some inconsistency and discrepancies around just the timing of survey responses, when they accessed services versus not. And so we had to adapt the survey a little bit more. But I think what was most surprising is that many individuals weren't even aware of the existing financial resources available. And these were people who had already gone through a transplant. So that also says we had work to do in terms of informing our patient population. But now I want to switch and talk about quality of life. And I think in terms of doing so related to transplant, it's also important to understand quality of life of someone living with sickle cell. And the literature suggests that both adults and children with sickle cell have impaired quality of life compared to even those with other chronic diseases. And in fact, data has shown that about a third of adult patients have more depression. They also have higher healthcare costs. There's also been data looking at either hydroxyurea use or adherence on quality of life, and saw that those with poor adherence had lower scores for social isolation, fatigue, pain, and mobility on their quality of life assessments. And then we participated in an initial study that looked at quality of life in the first year after transplantation, and again saw that those who were transplanted had lower quality of life before transplant. And then unfortunately, in that first month after transplant, that went even lower. But then over the course of the year, it actually improved, but didn't quite get to normal levels. So that's where it also suggested maybe we needed to follow these individuals over longer term. And actually, earlier this week, our paper was finally published where we looked at just that, the long-term quality of life after transplant for sickle cell. And so we used the PROMIS measures, which is actually the work product of our government's National Institute of Health. We use two different domains, which are solely designed. One's more of a pediatric domain, the PROMIS 25, so it's written in a language that children can understand. And then the PROMIS 29, which is the adult equivalent, which really assesses mainly the same areas, but incorporates sleep disturbance as well on the adult assessment. And what we did here was reported an interim analysis. So this is still ongoing. So we looked at about 4 or 5 years of data collection. And in our cohort, we are looking at individuals who are transplanted, individuals who have sickle cell but have not been transplanted, as well as even sibling donors, or I should say siblings, some of whom were also donors, to give a cohort of those who are not, or who do not have sickle cell. But given the sample size at the time of our interim analysis, the data I'll present and that was published is just that of the transplanted cohort. And so we only looked at the most recent scores. This doesn't reflect longitudinal data. And we did exclude any incomplete responses. And so just to give first a sort of demographic background on this cohort before sharing the data, you'll see that all of these patients were transplanted as children. However, we do have a good cohort of adults who completed the survey now several years after transplant. We have a pretty good balance by gender. Obviously, the marital status is just amongst the adult cohort, but still skewed a little bit more towards the individuals who are married. And interestingly, some people just didn't want to report their status. But we also importantly had low incidence of graft versus host disease, stroke, and in our cohort, which going back to the previous data, I think, certainly could have an impact on quality of life. And we also had low incidence of emergency department utilization after transplantation, which again is the goal. And so what's depicted here are the results of those measures, and green means normal, and anything yellow, orange, or red would be outside of the range. So first, we're happy to see no red. And also the vast majority of these scores were within normal ranges for these patients. Now, what we did see is among the children who completed the survey, there was some mild impact on mobility. And then amongst adults, there was some moderate impact on social participation, meaning those scores were lower than what we would have liked. So then we wanted to look at, well, what factors were influencing that? Is there something that we can modify or further investigate? For the children who completed the survey, we did not see any significant differences in our univariate analysis. However, for adults, we did see some trends that I think will need to be looked into further. And so, for example, when we looked at age of transplant, so the older you got or the further you were away from transplant, but specifically the older age you were at the time of transplant, your social participation actually increased over time. So that suggests that although those numbers are lower, maybe they'll continue to get better. We also saw surprisingly that, or somewhat surprisingly, that for every year in age you gain, physical function decreased. Now, again, it's unclear if that should be attributable to sickle cell and things like avascular necrosis, or if it's just a pure function of aging, and that as over time, sadly, all of our physical function will decrease. But we'll have to research and continue to look at this data. We also saw that in terms of time from transplant, there was some signal that there was a reduction in a reduction in your sleep disturbance scores, meaning over time worsening in sleep. Again, is that a normal function of life or something transplant specific? And we saw that women had higher fatigue scores than men. And so ultimately, given this data, we can see that long-term quality of life after transplant actually improves and gets you to levels that are considered normal for general populations. And this is also normal compared to what we've known about those living with sickle cell disease in the past. And so that's excellent findings to see, including the facts that there are continuing trends over time that we may have further improvements as well. But some of our findings about gender, age, and time from transplant warrant more investigation, and in particular, to better understand, do we need to provide better support for individuals after transplant to support their social participation? Do we need to look into other comorbidities that might impact mobility and physical function? Should we better assess, sleep and those things, in particular looking at gender as a mediator of outcomes like fatigue and otherwise? So now that we've set the stage in terms of, well, what does it cost, the simple cost analysis, what is the quality of life? I think it's time to then get into the modeling and looking at the cost effectiveness. But before I do that, like I said, I want to set the stage of the landscape. Because when we're modeling these costs, it's important to look at, well, what's your sort of maintenance or preventive care compared to your curative care. And in the US, we're fortunate to have a number of newer maintenance therapies that are now on the market, including L-glutamine, which was approved in 2017 and is available as young as age 5, voxelotor, approved in 2019, and I want to say in 2021 or 2022 was extended so that the age of use is now down to age 5 years, and then crizolizumab, which I understand is no longer available here. And of these, honestly, voxelotor is the only one. But crizolizumab is still available in use in the US for those age 12 and up with pain. And in fact, actually, a group at the Institute for Clinical and Economics did an assessment of the costs of these treatments. And you see the numbers here. It costs a lot in the US to give or provide these drugs, anywhere from $30,000 to $90,000 a year. But in doing the cost effectiveness analysis, they also factored in quality of life, and saw that when you adjust for quality of life, well, then that cost may become valuable or reasonable, given that a patient with sickle cell can cost about $1 million a year with previous therapies. And in this case, you're gaining some quality of life there. And so this analysis suggests that we should put everyone on L-glutamine, which we can talk about specifically why maybe we shouldn't. But in terms of cost effectiveness analysis, I think it's also important to consider, again, perspective. And if you look at some other variables, well, maybe that calculation isn't quite right. And in particular, if you look at out-of-pocket costs avoided, or school attendance, meaning the days that children are actually able to go to school instead of missing, or even caregiver burden, then it actually says, well, maybe crizolizumab is more effective and more beneficial in that case. And so again, it's important to sort of dig into the weeds of some of these analyses to understand what impact you're really seeing. So our group actually has done some work looking at standard of care compared to matched sibling donor transplant. And so when we look at overall survival compared to standard of care, and even modeling for some of those complications that we know can influence cost, matched sibling donor transplant still wins out in all facets of the model. Then we added in the cost of a transplant, and still matched sibling donor transplant seems to have a cost advantage over standard of care therapy, including hydroxyurea and transfusions. So it suggests that this is a cost-effective strategy and approach. And next, we're actually actively working on incorporating quality of life data into this analysis as well. So I hope over the course of the last several minutes, I've created a landscape that's, or a background that shows that there may be some cost savings with some of these newer preventive agents, but longer term utilization and impact is unclear. And even in the context of that, we also have transplantation, which is successful, proven, with great outcomes, even despite the high costs. And in part, that's despite the high cost, because one of those great outcomes is improvement in quality of life. And specifically, matched sibling donor transplant may have the best advantage of all of these therapies. But then what about the future? Although I guess in some ways I should have adapted the slide, because the future is now. And in particular, as we're talking about gene therapies. So I know the UK was a little ahead of us in terms of their approval of gene therapy, at least in your higher body regulations. But our FDA in this past December just approved gene therapies for sickle cell disease. And so prior, or just shortly around that time, several publications came out trying to predict the cost effectiveness of these therapies, knowing that they were going to be coming to approval and even hopefully to market. And this is another analysis by that ICER group that did the crizolizumab, glutamine, and voxelotor analysis. And what they did is used a baseline price based on the previously approved thalassemia gene product of $2 million to look at cost effectiveness from a healthcare and a societal perspective. And they found still across the board, no matter what threshold you use for the vast majority of these analyses, that price point was cost effective. I, in collaboration with a group out of the University of Washington, did a similar analysis where we actually used a publicly reported data on actual patients and their utilization, and modeled potentially eligible gene therapy candidates and their standard of care and their cost of care to try and determine the appropriate price point. And again, we saw if it were priced at anywhere from 1.5 to just over $2 million, that still could be cost effective. And we even used two slightly different models just to see if it was something about our model that was different, and found that consistently that was the price point that still could be cost effective within our health system. But surprisingly, I think around February, both of these companies announced their price point, and Bluebird was well above all of our models at 3.1 million, and Vertex was 2.2, so within some or just above some of the models that were currently available. So this is a lot of money, even in the US health system. And, you know, also understanding that we're talking specifically about sickle cell and a sickle cell gene therapy product. But the reality is that the number of gene therapies in the pipeline and under development are vastly increasing, with a number quoted as high as 2,000 2 years ago. So certainly if we're getting 2,000 gene therapies for however many patients, if they're all at $2 million, that's going to have a significant impact on global healthcare expenditures. And there's an estimate of almost $20 billion by 2027 will be spent on gene therapy alone. So then how does that impact access to these treatments, not only throughout the world, but potentially in the healthcare settings where patients need it most? And in the case of sickle cell, the vast majority of these individuals live in places where their financial resources aren't as high as some other places. And that's what's largely depicted here, is that the vast majority of those living with sickle cell are living in areas that, if you sort of correlate back to the other map, have lower healthcare expenditures and similarly have lower gross domestic products. And specifically, you know, I mentioned the cost of care for sickle cell in the US, but in the UK, a publication from 2015 showed that even way back in 2010, 2011, the cost of care was just over or just about 19 million pounds. And again, if healthcare costs have been rising over time, and now we're talking about gene therapy, what's the impact that will have on the UK? And again, like I said, how do we consider that in the global landscape of caring for individuals with sickle cell? And as Dr. Coley mentioned in the beginning, now, you know, as I said, the time is now. We're really being faced with these questions because just recently the thalassemia product was made available here. And there has been similar discussions of the sickle cell gene therapy product coming to the forefront at an estimated price of around 1 million for the UK. And so what does that mean in terms of approval, access, and impact on the health system overall? And so that's where I sort of want to leave you, is that how do we address these issues, not only from a personal healthcare system perspective or a personal perspective in terms of our patients, but also as a global citizen when we're talking about helping patients and families make the right decisions in terms of their care, and ideally giving them the access to all of the best possible treatments available. But understanding that this is a complex dynamic because it's not just the patient and the provider and the healthcare system. There's the issue of donor availability, there's the issue of economics, and all these other factors, and even societal factors that are in play that often come into this decision making. So what I at least hope that I've provided evidence for, and at least, you know, given evidence for the larger academic community who's making these decisions, is that, you know, yes, these come at a cost, but there's potential, I would even say substantial benefit to patients and families in terms of what they're gaining from these treatments. And given that, how do we work with our governing bodies? How do we work with our communities to try and ensure that patients and families have access? So with that, I just always acknowledge the patients and families who inspired and participated in this work, as well as the many mentors and advisors I've had in my career over the years. And of course, the friends, family, and supporters who keep me going, and my funding sources. And with that, of course, I cannot thank you all enough. Oh, I should change this, sorry. There's Portuguese. But I cannot thank you guys enough for, I could actually say now at this point, thank you in 5 languages. But thank you for those who have supported me on these visits, and those of you who've listened to this talk now so late on a Friday afternoon. And I will open for questions.
Thanks, Staci. A really thought-provoking presentation. Really fascinating work. Shall I ask if there are anyone who has any questions before I pitch in?
Before
Has anyone
you
got
jump
anything?
in.
Has anyone got any questions to ask Staci?
I see a hand.
Dr. Sohal.
Yes, the Dr. Mamta. Yes. Hi, Staci again.
Hello.
That was really excellent. I was just interested in the crizanlizumab. So I didn't know that was still available in the States.
It is.
And there's no, they're not providing any more based on the STAND study. No.
No, so it's still available in limited settings, and they actually are still doing some studies looking at its use, like for priapism and other sickle cell associated conditions. I will say, although it's available, not many of us are using it. I think one of the challenges, and this is again why you must do long-term studies. You also must do sort of post-trial evaluations and other sort of assessments of populations, is that we all know the real world is very different than a clinical trial, and there's a lot of controlled, there's just a lot of control about, in particular, medication use in a trial that's very different once you get it into the real world use. And I think crizanlizumab may have suffered from some of that, whether that was sort of self-selecting for populations that might tolerate it better, or whether that was for, other outcomes. But in our experience, Criz hasn't lived up to our hopes as some of the other agents.
Yeah, I would agree. I mean, with us, it was just it's a rule of 3, wasn't it? So it's a rule of thirds. So a third had no difference, a third felt better, and a third actually felt worse. So it was
so
tough for the third where they actually had benefit, and we had to say we can't give it
Stephen,
anymore.
We were 50-50. It was either it worked great and they loved it, or it was terrible and it actually caused pain and side effects and other things that we didn't even have that third. It was just either you loved it or you hated it.
So can I ask a question? My question is really about the access piece, because I think that's a really interesting element of your work. And though in the UK, because of the NHS, access issues aren't as stark as they are in the States, but they still exist. So I guess my question relates not just to the big shiny sort of cellular therapies, but going basic, and access to things like hydroxycarbamide, access to actually good clinical care, so decent follow-up. And as you know, I don't understand children. I'm an adult hematologist. So
I hope your daughter's.
You're a father. You do understand children. You do understand children.
But I'm talking specifically about sort of holistic sickle care across the United States. How stark is the variability?
So I think that's a great question. And again, sort of, in this journey, is one of the things I found is that in many ways we're similar, and there are far fewer differences. And one of the similarities, sorry, calling me, is that we have sort of healthcare deserts. And in particular, specialized sickle cell care is available largely in urban settings, commonly associated with academic centers. But the reality is that also often those places have very high costs of living. So the patients aren't necessarily able to get to those areas, or if they do, it's with financial burden. And so we do have similar challenges in terms, we have some patients that are coming 3 hours for their sickle cell care, right? And so how do we bridge that gap? And we've approached it in different ways, having satellite care facilities that our doctors go to, or, in other countries, they go to people's homes, or they partner with community health workers so that they're doing the hands-on work and then reporting back to the sickle cell specialists. But ultimately, the reality is it seems no matter where you are in the world, that is a challenge. And how do we address that? Telehealth is the other thing that's come up in terms of ways of addressing that. And so I wish I could tell you that everyone's getting exceptional care, but that's not honest or real, right? There are still people in places in pediatrics that aren't getting that. And then in the US, it gets even worse when you transition to adulthood, because there's a steep drop off between the number of pediatric hematologists, sickle cell specialists, and the number of adult hematologists. And so if we have 3,000 patients, where are we sending them? And so that's a challenge as well. And we're working really hard to be excited about sickle cell and excited about that, so that we're making trainees excited about it and wanting to go into the field, right? But until we have this workforce, we have to figure out a solution. So that also means partnering with primary care providers and ensuring that they're well-versed in sickle cell care to be able to do the work and also know when they need to refer. But yeah, it's a huge challenge. And that's, as you said, just for basic care.
Yeah, exactly.
Which some would argue, though, so if you can't even get the basic care, then why not just cure the sickle? And then, because then that adjusts for, right? That adjusts for not being able to give these individuals the care they deserve. But, we also have to ensure that we first do no harm. And so that if we're able to provide these cellular therapies, we have to ensure that we're granting access in a way that we're doing our best to ensure the optimal outcomes that we see in those study settings.
Thank you. I know Patrick's got a question, but can I just ask something very quickly? And apologies for the background noise of giggling. So just to ask, what are your thoughts about what we can do in those, because you quite eloquently sort of laid out the picture in relation to the lower and middle income countries, and what are your thoughts about those countries and what we can do to try and help in that situation?
First, I'll say I don't think it's a one size fits all. So I think different places have different resources, manpower, things that other places don't. And so in some places, it may be a partnership with the UK or with the US or with, centers that have the resources, so that there's I don't want to say a sharing of patients, but, a collaboration in providing cares. Some places, I think, can do it on the ground if there's the training and the staffing and the infrastructure. I think also the last thing we're all optimistic about is that now that this is a real thing, because I remember being in med school and gene therapy was this like, whoa, gene therapy, it's still like this theory in the sky that maybe one day will happen. And then now it's happened. And I know I present younger than I am, but I was in med school a long time ago. And so now that it's here, though, we also know that just like other advances, it will rapidly increase in terms of technology and the skill set and ability. We're already talking about non-chemotherapy based approaches to gene therapy. We're talking about in vivo versus ex vivo. And so a lot of those advances will also come to play in terms of increasing the access as well. And so I think we can do all those things in terms of creating a dynamic for lower middle income countries to have access as well. But I don't think we need to wait for like the easier, fancier, right? Because a lot of the infrastructure needed, it's a big infrastructure, right? And some people on this call are already working on creating some of the infrastructure in places. And so there are people out there doing that work that makes it truly tenable. And so I think it's championing that. I think it's also doing this kind of work that does the math that says there's value in supporting that. That will get it there. So sorry, that was a long answer, and I know.
No, I shouldn't have asked the second question. I just couldn't help myself. Patrick, been very patient.
Yeah, thank you very much. I think it was a great presentation, but I think the element that was missing was patient advocacy. You didn't seem to mention any at all throughout your presentation. Now, as a chair of the PPV group in West London, I would like to know how influential and how organizes patient groups and throughout the system from ordinary hospitals all the way to sort of political systems and so forth, because there's a lot of challenges. And really, I don't hear that collaboration with patient and patient leaders or patient groups. Wouldn't they help to drive sort of this thing a bit stronger? Because, I mean, you demonstrate quite clearly financially, there's still huge cost savings by all this sort of intervention you sort of mentioned. So, I mean, it'd be great to have in your presentation the effect and the influence of the patient throughout this system.
Yes.
Even in research. Thank you.
Yeah, no, that's hugely important. And admittedly, some of that is in a different talk. And in part because when we talk about patient-reported outcomes, that's a broad area, which includes some of this patient voice, patient advocacy that you're talking about. And so one of the things that we have done, and even actually how some of this research came about, which is why I thank the patients and families, is that we, in essence, started a post-transplant community group, for lack of a better word. And we have an annual symposium. It's like a reunion where everyone comes together and they get together and they talk about what their lives are like after transplant, what they wish they knew, what they need to know. And then we also invite people who haven't been transplanted to that as a way of being able to get questions and information from this group, but also to voice their questions and concerns. As I alluded to, we have 3 cohorts, right? So those who were transplanted, those who have sickle cell, and they're all a part of it. And so a lot of these questions that we were asking were some things that, yeah, I thought of, but also some things that in talking to patients and families, they said, we really want to know this, or you're not really appreciating this. And so that's where this work has come from. But we also have to, I mean, we live in a world, and especially in us where it's dictated by insurance. When we say, well, we want to transplant this person, insurance says, well, there's no publications that say that it's beneficial, or where's the evidence that says that this therapy is better than that, right? And so that's why we then, based on that information, we did the work and did the publication. The other beautiful thing that we do about this reunion is we also, in addition to getting their voice, we report back. So you said you wanted to know about financial hardship. You said you wanted to know about fertility. Well, this is what we found so far from your, so actually I have a whole nother presentation about fertility after transplant. But even having said that, I do think and maybe this is the snapshot that I got, that in many ways your patient advocacy is a lot more coordinated in ways in the UK than ours is in the US. But we still do everything we can to partner with individuals who have sickle cell, so that we're doing the work that's most impactful for them. But I also know that we still fall short even with our efforts.
Thanks, Staci. I know we're over, but are there any other questions from anyone before Staci's returns? Actually, oh, Ralph.
I was just going to ask about potential reductions in cost of the gene therapies that are being made available. Do we think that's going to be, what would be the opposite of exponential plunging or what have you in the future? Do we think there is a possibility that
Yes.
it will get more affordable?
I'll say it quicker and easier. I do think it'll be reduced again, whether it's the improvement in technology or our ability to give it, or also if we think about, I also remember when we published the genome, right? and how expensive it was to sequence just one gene, right? And still in that short period of time, we've gone to like, it costs thousands to do one or two genes, to like, I can do a whole exome for the same amount. So I'm optimistic that yes, the costs will also drastically reduce, and that yeah, I won't get into my editorialization about why things were priced the way they were. So I'll stop there. Yes, I'm optimistic.
Yeah, I would just add, I think the term I'm looking for is exponential decay, I think. But I think that decline will come with us being able to, well, I think the biggest cost at the moment is the centralized manufacturing. And if that can be sort of attenuated.
Well, and that's the other piece. I mean, we, our silver lining COVID views, right? What did we learn from COVID, right? So we did learn that we could share technology and intellectual property in a way that companies did not feel was disadvantageous, and then therefore share production, right? And so since we've proven that model, I think that also will play into reducing the cost of gene therapy as well. Now we got a new question. I don't know.
Yeah, but as you said, sort of the in vivo gene therapy is the way that we hope to go, which will be significantly cheaper. Barbara?
Oh, thank you, Staci. It's just a very quick question. Do you have any sort of feedback from the donors? I know you have the group meeting with the ones that have had, the post bone marrow transplant, but the donors, it would be good to get their perspective as well and their feedback.
Yes. So that's a great question. And I will say the areas where we really need to do more. Well, so there's three buckets that the access initiatives are starting to look into more: the donors, the caregivers, and then the people who never got cellular therapy, right? So we're trying to understand, one, well, okay, it's available, and someone actually even gets to a transplant center, why don't they go? We haven't captured that well. And in terms of the donors in particular, there's a lot of psychosocial aspects of pediatric donation and having a sibling donor who's also a child, and what the ramifications of that are. So that also limits our ability to really assess, but also maybe increases the importance of it. And especially now also that we're talking about, even I can't remember if that was here or somewhere else, but even with the haplo donor setting where it might be the child of a recipient and the impact there's a lot of layers to impact on donors that need to be fleshed out in a way. And so we are assessing the donors' quality of life. We also have their voice in the setting, but we also appreciate that this is a setting that's more about those with sickle cell. And so sometimes they may not be comfortable sharing that voice. But I think once now we're getting to a critical mass of more donors, we can really get into more discussion with donors as well.
Thank you very much. Yeah, thank you.